Okay, I have it that it's 9 o'clock, and if it's all right with all of you, we'll go ahead and get started. Today is September 7th, Tuesday. This is the Oregon Educators Benefit Board Strategies on Evidence and Outcomes Work Group, and I'll call the meeting to order. Glenn has sent out the package for your review. We have the agenda. As you can see, we have a relatively short meeting today. A lot of it is kind of the start of the year review of what SEOW is all about. We're going to talk about work plan, and then we're going to get into the one debate we had that we left for our consultants to do some work on, and that's the diabetes care vendor comparison, and then whether or not we wanted to add in WW for diabetes. So that's our day for today. And with that, the first order of business is to look at the June meetings synopsis and to see if there's any changes people want to make. Otherwise, we'll accept it as described. A motion to approve?
So moved.
So seconded.
Thank you. All in favor, say aye.
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 Okay. Jeff, I assumed there was an aye that squeezed out. I just didn't hear it.
Oh, you didn't hear me. Okay.
Yeah.
Thumbs up.
Okay. Thank you. All right. On to the order of business of the looking at our charter and roster. Glenn, I figure you and I would tag team on this one. Can we get the roster up first? I know that's, and Rose, I assume you're driving this. If you could switch it to the roster first, I think we want to, it's probably important that we look at it first. Okay, so on my screen, it's barely visible, but what you'll see is the three of us, Robert, Jeff, and myself, are carryover members. And we lost Bill from last year. So we are a committee when the board is fully, when the board is filled, we're hoping for 5 members. We're down to 3. And I know that one of the big issues that the board will be talking about this afternoon is filling in those positions. What I have asked Ollie is that when we identify people who will be joining the board, that we would ask, even though the approval process takes time, my hope is that we would be able to ask them to join as soon as possible, even though they may not be voting members because they hadn't been formally approved for being on part of the board.
Yeah, I think that's a great idea, Tom, and we should have some solid replacements, which I can get into in the board meeting this afternoon.
Great. And the only additional question that I have, and this is for you, Robert, I guess, and also Ali, do we have a sense of whether or not there's any current board members who want to join this group?
I have not had anybody reach out to me and ask to be on SEOW at this point, other than Bill. Well, and he didn't reach out specifically to me, but if he recaptures his seat on the board, then he'll also probably be the OSBA representative for OWEB.
Okay. Maybe at this afternoon's meeting, we could tell the rest of the board that there's an opportunity to join, the most interesting and dynamic of all of the OEB involvement, which is SEOW. So we can give people that opportunity.
That sounds great.
Agreed.
Okay. Obviously, the rest of this page shows the participation of SEOW staff and then consultants, and then our carriers and their very critical component or participation in this. So other than just filling our open seats, does anyone have any questions or suggestions for changing the membership for SEOW? Silence means that no one has any suggestions. So, Rose, could we now move back to the charter? Great, thank you. SEOW's been around for a long time, and it has been. It was the subset of the board that was there to get into the details. In other words, to get into the weeds and truly understand some of the interesting and challenging issues that OEB confronted with early on, and it continues the work group roles. As you can see, it's mainly looking at the effectiveness and quality of the care provided by our carrier partners. It also has been the place that we've tried to vet new benefits. So it's been a time where we've really been able to have in-depth discussions. The final thing that it has done has been this, the forum around which we have dealt with the workplace wellness programs and the like. Is there anything in this charter that board member or committee members feel we should ask for a change? When I looked at it, I thought it was still relevant.
I agree, Tom. I thought it really covered things quite well.
Yeah. The one thing that we did add to it was over the last 2 years, there's been, or 2 to 3 years, there's been the innovation work group, and the idea was to hopefully translate the issues that are part of the innovation work group to the specifics of OEB. We've done that in particular looking at centers of excellence and reference pricing. So that, I think, is an important addition to make. I'm hearing background conversations. Can people please, if you are, please mute if you're not in a way recognized and talking. Thank you. I think it went away. Okay, so the charter is what it is. If there are no changes associated with it, I think we can probably move on. Glenn, did you have any additional points that you wanted to raise on this?
Yeah, the only thing that you kind of touched on it, Tom, is that the really kind of coordination with the innovation work group and how they've taken a role, especially if you look at letter I under the roles, really servicing as a forum to look at overall, service changes. So for both OEB and PEB.
Okay, so it says on our agenda that the action piece is to agree that this is what our recommendation is for the for SEOW to move forward. And if there aren't any objections, I will, when I give the SEOW report today, I will bring this to the board. Ali, do you think, is there a need for the board to approve the charter if there isn't any substantial change, or is it just to acknowledge that we indeed do have a charter that details what we're about and how we work?
Yeah, I don't see a need for the board to take a vote, Tom. I think just an update would be fine.
Okay. All right. Okay. All right. Now we get into the nitty gritty, and this is the 2021-2022 work plan. And again, I think Glenn and I will tag team on this, but Glenn, I want you to go ahead and have you kind of take us through the calendar of activities.
Sure. And just to kind of start off, you know, this, as we've done in the past, is a draft work plan. It will change over time due to new items that get placed on the agenda or just reprioritization. But I'll go over the individual items. Of course, September, we have, as Tom said, you know, we're doing the work plan, the charter, the roster, and we will be at Willis Towers Watson will be providing a comparison of our diabetes management services and a recommendation for Weight Watchers for diabetes. October is going to be devoted right now to getting the, used to be a quarterly, but we've moved to more of a 6-month COVID impact report for our medical, the prevention and early detection services, plus a telehealth utilization report. And then dental would again be the utilization and the prevention and diagnosis. We moved to a more 6-month instead of a quarterly, so it would be in another 6 months after that that we would get the next report. So unless anyone has any, you know, feels that that should go back to a quarterly, I think that would be the proper thing to do for now. Okay. Next page. November, we're going to get a report from Willis Towers Watson is going to provide a report on the MODA PCP 360 program, looking at a number of factors, including engagement on that. We're also looking to do a report, you know, we haven't done in a long time, on how the PCP, PCH, and CPC Plus has been working for our carriers. You know, probably looking at things, number of homes, their levels. We still need to kind of flush that out, but that would be really a good report to have since we haven't heard that on that for a while. The next thing would be an EviCore report, kind of an annual report on its utilization, effectiveness, any information on the impact of the increased waiver visits. And then if we have data on information on, you know, are we getting any type of kind of complaints, or what has been the feedback from our population. The next would be the MODA 360 report. That would, you know, since this has really been the first year, to see how that report is working or how that program is working. December would be our annual wellness reports from our vendors and carriers. We also, for December and January, will do for any really round 1 and round 2 of any new carrier recommended benefits or programs, both for the medical and then the dental and the vision plans, for SEOW to vet, provide any, get any further information, and then make recommendations to the board.
And Glenn, just it would be also nice there where we have the carriers coming in with recommendations. We should be seeing whether or not OEB staff has had recommendations coming in from directly from members about new benefits. So we should just that topic should be new benefits, and there'll be the recommendations from carriers, recommendations I guess from our consultants. I'm not sure if they've done that, but then also then from our customers.
Okay.
Thank you. I'm sorry for the interruption.
No. Please, as I go along, please feel free to interrupt here and ask any clarifying questions or any additions or changes on that. January would be our wellness program recommendations for 22-23. That would be the costs and then the recommendations from Willis Towers Watson and staff. January also we'll do our annual ACT report for 2021. One of the things we'll work through that also in that report would be to give the status of, because it's relevant for any ACT recommendations, is the status of the COE project that the Innovation Work Group is working on.
And COE, Centers of Excellence.
Centers of Excellence. Sorry about that. Yeah.
It's okay.
And next page. And then we also in January will have the round 2 for the medical and dental and vision plans, new benefits or programs. February is going to be, we're going to have the annual pharmacy report, but also carrier programs, including the oncology site of care, which is, I believe, about a year old. So we to get a report on how that's been working, because that was a program that was specifically designed to help reduce oncology costs. And then any if we have we needed more information for the wellness program recommendations, then in February we can make the final recommendations. And then our medical quality performance measures, the 2022 performance report. March is open right now, so any new or items that come up can be done in March, especially if for whatever reason, if we did have added items that needed to be vetted before it went to the board for the renewal. And then April and June would be the annual health report and annual dental report. And then September is also open. That's kind of in a nutshell what the plan is right now. So I would just, ask, do people have any questions right now, clarifying questions in regards to the items we have on there?
Board committee members, any comments?
No, other than the sequence looks good. I'm finally getting to the swing of how things go year to year and the months in between. I think it's very thorough.
Jeff, comments?
I agree with what Robert just said.
Glenn, the only thing that I would pencil in for March would be the repeat of the October discussion around telehealth and prevention. It's 5 months from October, but it will. I think that the annual health report oftentimes takes up the entire meeting, so I would like to slot that there. so that we don't miss out on that. The other thing that's going to be happening is as the other work groups that are circulating around OEB come up with their work, we'll be moving those ideas into SEOW for conversation. As Glenn just described, the Center of Excellence work that is being done by the Innovation Work Group, that information and discussion we will need to populate into this. So what you see here in our work group, in our work plan, is not the totality of our work, but it's in a way, the placeholders that we need to get to, and then there'll be additional things that come along.
Tom, where did you add COE?
We haven't yet, and I want to see when the Innovation Work Group will be, they think, done with their, when there'll be, important decisions to be made. And when we do that, Glenn, we should probably include impact on reference pricing, because the topics that we have been looking at in regards to centers of excellence, several of them also fall into the reference pricing bucket.
Yeah, we probably need to get that done by January. I know we're waiting on the Innovation Work Group, but there's a domino effect with other pricing, so. Right.
Okay. So Glenn, you and I can talk more and see when, and it may mean, again, looking at all of the staff that's working with the Innovation Work Group, and see when we'd be able to bring something to SEOW. I mean, and the idea would be for SEOW to look at it ahead of time, and so that we can have that presentation to the board.
Oh, okay. Have their recommendations go to SEOW and then to the board.
Yeah, I think so.
Yeah, it'd be nice if we could get our first look by December and wrap it up in January.
Yeah, I mean, I think we can move some things around if we have to.
Yeah.
Yeah, we probably could, or just extend the meeting. I wanted though to bring up one thing that came up is Standard is going to be doing their new 3-year renewal, and so it was Wills Towers Watson had suggested that a Standard presentation be done on kind of how it's been operating. Engagement, payments, claims, that kind of thing. And so probably in November, December, do we want that to come to SEOW, or is that something that should go directly to the board, since it would be the board making the final decision on that?
Well, I'll speak up on that. It's a great question, Glenn. I think SEOW is probably most interested in the disability side of it. But I mean, that's just my opinion, that the life insurance could go directly to the board.
I don't have it's not an area of my expertise, so I would really leave it to Robert and Ollie to figure out how best.
Yeah, I think if it doesn't need, a specific focus on it from this group or studying impacts, then I think it's probably more appropriate at the board level, at least my initial thoughts on that. I'll talk to Ali about it.
Yeah, I think that sounds fine, actually, Robert. I agree.
Yeah, and I would agree on that, because I know when we had the standard report before, the main thing that SEOW was possibly interested in was their return to work program, but the rest of it, like you said, life insurance, disability, and it might also be good, since if we have new board members coming on, to kind of give a background on the program itself.
Okay.
All right. That was one. We did have, and this can be kind of penciled in, Tom. We can talk about it. Wills Towers Watson had suggested they're going to be doing a mental health resources report, and that having to the board, I believe it's in December, have a similar one, maybe more detailed, come to SEOW. We could do that in March,
Okay.
since we're pretty open.
Yeah, that'd be great.
The other issue too is, cancer continues to be a high cost area for SEOW. Now I know 2 years ago, part of the IWGs they looked at overall costs, and I believe cancer was one of their areas. And they did come up with, I think, the site of care program at the time. And I believe SEOW did look at this about 2 or 3 years ago, a pretty in-depth report. And it, from what I remember, it said that our carriers were doing well, but could improve in some areas. So I'm just wondering, do we want to do another do you think it's a good to do another in-depth kind of deep dive, so to speak, of the cancer?
I think that the challenges, the changes that we're going to be seeing in Oregon are not going to be disease specific. I think they're going to be funding and the organization of funding different. What I mean by that is there's going to be much more around the move towards total cost of care, around site of care, and the whole area around value-based purchasing. So I personally am more interested in looking at those issues, because I think we're filling in our time. And when we ask our consultants to do a deep dive into cancer, we are saying, and we acknowledge you don't have time to do something different. So if you ask me personally, I think that we will fill up SEOW's time and our consultants' time as we look at the issues, continuing to look at the issue of the impact of the hospital, 200% of Medicare, the value-based purchasing movement that's going to be happening, and the other issues that we've, centers of excellence, reference pricing. That's a personal opinion. My opinion can be changed though. Other committee members, comments?
I think keeping March a little bit more free makes us more nimble in responding to the pieces that'll come up.
Okay. All right. So, Glenn, I appreciate you raising that issue, and we will see how it plays. But I think that for right now, let's hold on that as an initiative.
Okay.
Any other areas that, Ali, I'm going to ask you, are there areas that you are seeing over the horizon that you want SEOW to be thinking about and looking at over this next year?
Yeah, the one I was actually going to raise is, you know, I don't know that it needs to be called out specifically in a work plan, but just the health equity, and, you know, identifying maybe some of these areas, benefits, services, you know, run them through the health equity lens, you know, through the joint committee that you're on, Tom. I think additional cost here maybe would be one, you know, that would really be worth, or make it part of Willis Towers Watson's analysis. But I think, you know, maybe getting reoriented to health equity on this committee, or keep it at the board level, you know, is something that we could talk more about. But to me, that's the one that sticks out.
As you're raising that, essentially at every time we go through this, each of these topics, we should be saying to ourselves, are there specific groups that are being impacted adversely by what we're doing? And, you know, it's going to be, you know, even as we talk about WW for diabetes today, we should be asking ourselves questions. Okay, this is a recommendation for the whole. Are there subsets of our community that we're caring for that are impacted by the decisions that we make? But I appreciate you saying that. That needs to be kind of that each of our presentations need to be asking that question. And it's very possible that the answer is going to be, we don't know, because we don't have the data that is broken down according to language and culture, race, ethnicity. So, you know, gender preference, all of those things. We may not have the data, but we should be essentially at every topic, you know, throughout it, asking, okay, as we look at this from a health equity standpoint, what's the impact? Are we able to find out anything? So that'll be one of our checklists as we move forward this year.
Right.
Maybe what we can do is build that into our charter, especially,
Yes.
you know, when you talk about new benefits or programs, we should be looking at that.
Yeah, I appreciate. Yes, can you come up with language for that?
Sure.
So that will be the one add to our charter, is to add health equity component to.
So then my question is, do we need to now vote on the change in the charter, or is it?
I don't think so. I mean, again, we're kind of a consensus driven. If no one objects, it means that. But I appreciate what you're saying, Robert. It's review.
Well, I was thinking about that health equity last night, and equity is embedded in everything that we say here. Is there a need for us to expressly say it?
I think for us to make sure we're actually doing, my personal opinion, Jeff, is as you're doing something new, it's best to be explicit. It may turn out then, you know, after we've been doing it for 2 or 3 years, it may be built in, but it's not built in now.
Okay, so we have work group roles and we have guidelines. So would it fit up at the top? Where does it, under guidelines? Where does it fit on this? That's what I was getting at.
Yeah.
I think guidelines, because it is actually, we're saying this is a guideline on how our group approaches what we do.
Yeah, I would agree with Robert.
Okay.
Yeah, I think we talked
And
about.
I think it,
Go ahead, Robert.
I think it's important to put it in because we do have two open positions, and we, always seem to have an open position. And this charter document, I would suspect when we get somebody new, we would want to, give them a copy of this so that they know what we're about.
Yeah. Rose, I have a question for you. Does the SEOW packet that we all see, does that go get sent out to the entire board?
Mute. Sorry, I can't unmute.
Well, yeah, it comes and goes.
I can't.
Sorry about that. I shouldn't leave the mouse over the mute. No, I was going to say, yes, I include the entire board when I send this out.
Okay. All right. So the entire board seeing these things, how much time they're actually reading them and getting them to, we're not so sure, but it will, it will be important that, I guess my recommendation would be once we get the language set for the how we're going to be explicit about health equity in our conversations, that will be will highlight that for the board, and that updated charter will send out to everyone, whether or not, and Glenn worked with Rose to figure out who does that. During our break today, I will go back and get some language and around health equity, and I'll send it to both Glenn, you, and to Robert and to Ali, and see if you agree with that, and that maybe then we could, if it's okay, we'll then add that into the report that we give the board today.
Tom, I'm
Yes.
sorry. I wasn't trying to be rude. I couldn't unmute.
I understand. I saw it coming. Your name's there, Rose, to the side, and it'd be mute, off, mute, mute, off, mute, mute,
I'm
off,
sorry.
mute. It's all right. Good to have you on board.
Technology.
Don't talk to me about technology. I'm an old guy. I don't know what the heck I'm doing. Okay. So, Ali, you had the only thing that you wanted to make sure we were looking at was the our work through the health equity lens, and we'll add a piece to that and in our guidelines, and we'll get language set for the board meeting. Any other comments about the work plan? I have one more that I want to get into a little bit of detail on. Okay, so the one area, Rose, if you can go back to October, we end up on the very top of I'm sorry, it's November, my mistake. It is, you'll see at the very top, PCP 360 report. And Erica, join in here with me if you could. PCP 360 has been in place now for a year. Is that correct, or has it been 2 years?
It's been 2 years.
2 years.
This is the second year, yes.
This is the second year. Okay. So we have a whole year's worth of experience around PCP 360. And if y'all remember, this was the major change that MODA made in the beginning of 2021. And it was, we replaced the Summit Synergy. We wanted, MODA wanted to go in this direction because the previous coordinated care model captured less than half of their people, and it captured those who are at lower risk, not at higher risk. So the idea was to the model. Moda said we have to change the model. So the idea was to try to, again, increase the number of people who are in coordinated care, and to particularly to get the people who are at higher risk. And the preliminary information has been that it's been hugely successful, in terms of increasing the number of people who are in coordinated care model and those who are at higher risk. So this understanding the impact of PCP 360, I think, is really important for the board to understand. It was a major change. It helps move us towards value-based purchasing. There's all sorts of things that, that are behind this. And we need to understand PCP 360 from, all of its elements, its financial elements, its clinical care quality, and from a member service standpoint. So we'll look at it. Our hope is to be able to look at this from a cost, quality, and service standpoint. Erica, do you agree with what I just said?
Yep, it was a really good summary.
Okay, so what then the issue is going to be November. That gives you time for your team to put together that report?
Yes, I believe so. And we've talked to Willis Towers Watson about it a little bit as well.
Super. Okay, great. So I'm really looking forward to that. The issues are going to be, we may be close enough to where we actually can start looking at HEDIS results. Now, the problem with HEDIS results is everything's all skewed by the COVID and its impact, but at least there'll be comparisons, and that will be important. Okay, so that was the only other area that of the work plan I wanted to highlight for the committee. Anything else that people want to add? We're obviously way ahead of time, but we never know how much time it's going to take to go through all of this. And
could I just ask since we have a little time, I might just ask a question about the PCPCH and CPC
yes.
Plus report. So what would be most helpful here? Just kind of a primer on the difference between those programs and how they're similar or different to PCP 360.
I would think that for that report, Jenny, is what I was envisioning is a primer on what these programs are, but two, looking at, overall measures for these programs, such as for the PCH, you have, how many do we have, say, across state or cross coverage area? Then the next part would be what level are they at, because there's varying levels of complexity for that, but we can talk some more and on that. But the second thing is for the CPC Plus, that is a program I believe primarily based on, it's for primary care and it's based on coordinated payments. So that would be, I guess, again, it would be utilization, but also, amount of funding, cost. And then maybe if it's possible, say for the PCPCHs, to look at those at any HEDIS measures for those programs versus just the general population, just say a general PPO doctor.
Okay, that's helpful.
So basically looking at quality because they're supposed to provide better quality.
Okay.
Well, and I'm going to just add in there this may evolve to where we have there's work going on in the state around value-based payment, and we'll weave in whenever you have value-based payment methodologies, you have to also look at it from the perspective of quality. Cost and quality have to weave together, and I know PCPCH has been that's the patient-centered primary care home that has been in place now for the same time that SEOW has been in place, and it's been run by the Oregon Health Authority, and it has designations for primary care settings about how coordinated, how they are looking at quality, access to care. It has 6 different domains that they have quality metrics around, but it is one that is, I think, foundational to improvement in outcomes, and so understanding how well, and it's deeply rolled into the PCP 360, and it has been, foundational. The issues are foundational, I know, in Kaiser Permanente's primary care structure. So understanding it is, I think, is an appropriate thing, one, for the board, and then to see how those measures and how the innovations that come from that roll into the delivery system, because you can control cost very easily. You can say, we're not going to, you need a hip replacement, sorry, can't afford it, no hip replacement. You can decrease costs simply by denying care. We're not doing that, so we need to be able to do all of this balancing. Okay. Any other, are there, I'm going to open this up now to to our carriers. Anything that is on this that you have concerns about? Are there topics that we have missed? So I'm going to, we haven't heard yet from anyone from Kaiser Permanente, so I'm going to ask Dr. Bachman, Sapari, whether or not you have any additional comments that you want to make about what you're seeing here, both from the medical and dental standpoint.
No comments at this time. Thanks,
Okay.
Tom.
Yeah. Okay, and now I'm going to switch to MODA, and that would be with Erica and Dr. Singh and Dr. Barcello. Anybody, I don't know if anyone from the dental is on board today. There wasn't any topic, but Erica, maybe you can lead your team in this. Is there any additional things that we're missing, or any comments that you have what's on the list now?
Thanks, Dr. Silterbo. No, we don't have any additional comments. Glenn did let us review and ask a few questions prior to this meeting, so
Super.
we are all up to date.
Okay, and Willamette Dental, I don't know if anyone from, again, we don't have dental on our list today. I don't know if any of the Willamette Dental group is on the phone call this morning. Any comment, additions, or concerns?
Good morning. This is Tiffany Link.
Hi,
Nope,
Tiffany.
we've had a chance to review and we are good.
Great, thank you.
Thank
Okay.
you.
All right. So I obviously talked with our medical and our dental providers. I'm not going to go through each of the other groups, Reliant Behavioral Health and the like. But again, if you have anybody who's, any of our carriers, vendors who have concerns or areas that you think we've missed, please get a hold of Glenn, and we will talk about it and make sure we have meaningful things on the calendar. Any other comment from committee members? Okay. Otherwise, I think we have a work plan. Glenn, any other final comment?
No, this is great. I appreciate all the input here, and you know, like I said, it may be changed over time. Issues may come up, such as say from the innovation work group or other groups, and that we'll add in. But
okay.
It's no, I appreciate all the help.
Okay. Next on the agenda, Glenn.
The next item on the agenda actually is a break. And then at 10 o'clock, we were going to have Matt Sanders, I always mispronounce Matt's last name, Sandersky, from Willis Towers Watson was going to come in, and he was going to he's going to do the diabetes care vendor comparison and Weight Watchers for Diabetes recommendation.
Okay.
So
is he,
that was,
Jenny, is he available to start at 10?
Yeah, he should be available right at 10. I'll just give him a little heads up. But...
Okay, super. So I'm going to go ahead and we're going to break for 10 minutes, and we'll start up again a minute after 10 o'clock.
Okay.
All right?
okay.
See you all back in 10 minutes.
Hey, good morning, everyone.
How's it going, Matt?
It's going great, Glenn. Good to see you. How was your Labor Day weekend?
It was good. How about you?
It was good. It was very relaxing. Had a nice extra day off, and but back re-energized and ready to get back after it.
Do anything fun, like any barbecues or anything, or?
Yeah. I actually went over. I had some friends from Ohio, and we actually met over in Las Vegas for the weekend.
Oh, that's nice.
So went over there and met just for a couple of days and hung out and got to spend some time with them and relax. So it was a good time. Did a lot of walking.
Yeah, it wasn't too hot, was it?
Oh, it was unbelievably hot.
Um,
But it was par for the course. But it was a good time. How about yourself? Did you get any barbecues or anything out? Enjoy
no, just
friends, family?
actually work around the house more than anything, things that we had to get done. But we went out for dinner one of the
Okay,
nights and just kind of hung out, relaxed. You know, the temperature's good here in Oregon. It's in the 70s, 80s. So,
oh, good. So it wasn't too hot. I know it was a little muggy up there a couple of weeks ago. A little humid.
yeah, we've been getting some humidity. I think it's some of the smoke from the wildfires that keeps the humidity down.
Okay, I'm going to go ahead and gather us up again. It is 10 o'clock and we are rejoining. I want to make sure that Jeff and Robert are back on board. If you could say yay, we'll get going.
Yay, Tom, yay.
Alrighty. Jeff, are you there? I want to wait for Jeff to rejoin us.
Thank you. I'm back.
Great. Thank you. Okay. So we are on board. We are now, just as an introduction, we left our last meeting in June not coming to a conclusion of what to do for Weight Watchers for diabetes. We asked our medical carriers, what direction they wanted to go, whether or not to add Weight Watchers for diabetes, which we're going to offer it for our current plan year at no additional cost. There is cost, though, associated with this program that we would experience at a later time. So we gave it to our consultants to think about and bring back to us in the September meeting, and here we are. So we are ready to jump in. Matt, if you could introduce yourself, and I know you've prepared a deck for us.
Yep, absolutely. Well, good morning, everyone. For those who I did not get a chance to meet at the last SEOW meeting, my name is Matt Zendersky. I'm a health management consultant at WTW. I also support the OWEB wellness program and the wellness initiative and the rollout of our new WebMD1 platform that's going to be coming for the OWEB population on 10/1. So I'm super excited to be here today and give you an update and provide sort of the information and the background of what we found as we dug deep into your current diabetes and metabolic syndrome care solutions and sort of the question at hand. And Tom, you really set the stage there really nicely. WW currently has their program, their weight design program that's available through the benefits for OWEB. They have suggested now an opportunity for us to implement their WW for Diabetes program, and we thought before we made a decision about moving forward with that, let's take a couple steps back and fully understand what are the metabolic syndrome and diabetes care solutions that are currently available to the OWEB members today. How are they performing? And then what does that look like moving forward, and what kind of opportunities do we have? So I think, Rose, you're going to be helping me out here today with the slide. So if you want to go ahead and go to the next slide, after this, after the disclaimer. And then I think I have like a half an hour for the presentation today. So I will make sure we get through this information in a timely manner and leave some times for questions. But as I go through the deck, if you guys have any questions as I present this information, don't hesitate to sort of chime in, ask any questions. I want this to be a collaborative discussion and make sure that we get all questions answered so we can come to a resolution by the end of the presentation. So we already just talked a little bit of background. We're going to discuss this a little bit more in detail and give you a little bit more about background information of what are the question we're currently going to be solving today is. We're also going to discuss about the prevalence of diabetes, not only the prevalence of diabetes here in the United States, but also the prevalence of diabetes among the OEB population. We have some great data to share with you regarding that. We're going to talk a little bit about best practices and care management for members of diabetes, so really setting the stage of our groups who are really excelling and driving healthy outcomes and reducing the A1C numbers, the blood glucose numbers, the weight numbers among individuals who are diabetes. What are these solutions that they're currently implementing and sort of their strategies? We are going to take a look at your current resources that you have available and then talk about some things to consider and then recommendations and next steps. So Rose, if you want to go ahead to the next slide. All right, so just some background for pre-diabetes and diabetes here in the United States and the OEB population. So it's a prevalent health risk in the US and OEB population. We're going to take a look at what the data looks like here in a second. OEB has several diabetes care solutions to its members through their current medical plan and vendor partners, and we're really going to outline for those step by step what those look like today. Weight Watchers has proposed an additional solution to support members with diabetes starting in January 2022. And as Tom mentioned, there's no cost for 2022, but it could have a significant cost in 2023. And another thing we're going to talk here a little bit about, and another of the considerations is that while they have told us, Weight Watchers, there will be a cost, they have not confirmed with us what that cost will be. So that's something for us to keep in mind. And we have the best practices approach in diabetes care management, engagement and effectiveness of OEB's current diabetes care solutions, and then any duplication of services or gaps in your current solutions to inform whether that the addition of WW solution would be beneficial. So go ahead to the next slide, please, Rose. Awesome. So background, growing prevalence of diabetes, and I don't think a lot of this data here for the members of the OEB SEOW team is going to be shocking, but we just want to sort of set the stage of where we're currently at. So there's currently 34 million U.S. adults with diabetes in the United States. If you take a look at that top middle number, then I think the big thing to the right, and we're going to talk about this as we go through your data, is that there's another 88 million adults with pre-diabetes in the United States, and nearly 85% are aware of this condition. So these are the two things that we are currently trying to manage right here, is that you have the continuum of care, the 34 million of adult diabetes in the United States, or adult with diabetes, and then you have this another large chunk of data, this 88 million individuals with pre-diabetes, and a lot of these individuals aren't aware, and we're going to show you some Kaiser data that sort of speaks to how that falls in lines with the trends that you see. 2 to 3 times higher health costs, which we're going to see that as we take a look at your data. And then 20% plus of healthcare spending is for people with diagnosed diabetes. And then you can take a look at complications of diabetes and a cost per acute care episode where that usually comes in. You can see the ESRD, acute myocardial infarction, stroke, hypoglycemia, and then amputation. So I don't think there's any too shocking data here. I think we're all pretty aware that this is a prevalent health risk here in the United States. So let's take a look at what that means here for the OEB population. Rose, if you want to go to the next slide, please. So let's take a look at the OEB diabetes prevalence. So 5,500 OEB members had diabetes during 2019-2020 plan year, representing 25 million in spend. Diabetes has consistently been one of your top 5 conditions for OEB in terms of spend. So we see there's high spend, and historically among your population, it's been one of your top 5 conditions. The percentage of OEB members with diabetes has stayed relatively consistent over the plan in the past 5 years. So if you take a look at the data here below, you can see it pretty much stays stagnant. the amount of people that have diabetes among your population, and the amount of total spend that it amounts to.
And Matt, when
Yes.
I looked at this, and Rose, go ahead and switch to the next slide. When we talk about diabetes spend, I think it's important that we make sure we understand what that means. It is going to be the costs of the treatment for diabetes. So it's the medication, I assume it's the monitoring, lab monitoring, and things like that. It doesn't include the heart attacks that a diabetic has, or the kidney failure that a diabetic has, or the sepsis that the diabetic has. Am I correct?
Yeah, that's correct. That would be the diabetes is sort of the core cause, but then it doesn't capture what the ultimate condition is.
Yeah. Okay. And then so when you have incidence of 2 to 3 times higher incidence of stroke or myocardial infarction, the impact of diabetes is a compounding effect.
Yeah, absolutely. And Tom, it sort of goes in stages, right? Like you have the weight management issue, then the weight management issue ultimately becomes the diabetes, and the diabetes ultimately becomes the stroke or the amputated leg, or the end result of that.
Okay.
And if you see here, and Tom, that's a great segue into this next slide. And this slide is very compelling, is that OEB diabetes episodes costs are driven primarily by RX costs. And managing diabetes at lower disease stages is more cost effective for OEB. So if we take a look at the episode by disease stage, you can see how that there's a higher number of episodes in stage 1 and stage 2. But if you take a look at once we get into stage 3, you see the costs significantly increase. So we have stage 1, even though that there's more episodes, that you're only looking at about $2,900 per episode. Stage 2, you see that almost doubles to $5,100. And then once we get to stage 3, and Tom, this is where, you were just mentioning with the amputations and the strokes and those different, you can see that while the episodes and those numbers are reduced, you can see the costs are greatly increased. So it gets more expensive to treat these individuals as they go along.
Hi, Matt. Sorry for my ignorance on this, but could you just briefly explain the differences between the stages for me?
Yeah, and we can get exactly, because I want to make sure that I get the stages captured, but I would assume that this is your pre-diabetes, right? Your pre-diabetes, then your diabetes.
Well, I'll just interject. So
yeah, go ahead.
It's just the milder version of the disease state, and then stage 2 is a little bit more. And this data came from the data warehouse, so they have specific groupers for the different stages. Really, this is just showing you that folks who are sort of managing their diabetes pretty well don't have a lot of costs, but those who are sort of at the high end and more complex and or not managing real well are going to have a lot more costs.
Okay, so follow-up question then. So going back to the previous slide where the 4.2 is fairly stable, is it possible that, I just don't know how that graph mixes with the stage 1, stage 2, stage 3, because if the 4.2 was mostly stage 1 now, whereas 5 years ago is stage 3, that would have.
Yeah,
I think the answer is.
I know that's the spend, but we could have more people on stage 1.
I think
so. I don't know,
Robert. It shows the stability of the populations as they divide out between stage 1, 2, and 3. Because you're exactly right. If there was a huge migration to from 1 to 2 or 2 to 3, you'd have the costs would be changing significantly.
Yeah, I would agree with that too. It's staying relatively flat over the years. And also what that tells us too, Tom, is that, the people that are coming on your benefit plans, these teachers, these individuals, they're staying with your benefit plan, but their risks aren't changing, right? They're pretty much staying in the same buckets over the years. And so that's maybe something that we take a look at, interventions to help them reduce their risk and start to move along the continuum of care in the right direction.
I, for one, would appreciate a bit more definition on those stages.
Yeah. So if you
Also-
can get that to us, Matt
Yeah.
and Jenny, that'd be
Also
great.
coupled with ages, average age in those.
Yeah. And that's what we'll reach out and we'll get that information just so we know exactly how that's bucketed.
It just for
Great.
clarity, that's not a term that's used in the clinical world. We have stages for hypertension, we have stages for end-stage renal disease, but we don't have stages for diabetes. May make sense from a grouper standpoint, but that's not something you'd find in a textbook.
Thank you, Keith.
Thanks, Keith. Great questions and great dialogue. Any other questions before we move on to the next slide? No, good. All right, Rose. So now what we wanted to do is we wanted to dive into a little bit more specific of your OEB diabetes population, breaking them up between MODA and Kaiser. What are the current numbers among each group? We have current services and solutions that are available. How many of these members that have been diagnosed with diabetes are actually engaging in these programs that are offered by the carriers? So here is your MODA Health Livongo engagement report as of 4/28/21. This is the most recent one that I could pull from them when we were building the deck over the summer. It gives your total number of OEB MODA members as it goes throughout the year. Then it gives you the numbers that have been eligible for Livongo, so the ones that have been identified for the diabetes program. The number that have enrolled in Livongo, which in speaking with MODA and Livongo is right around their average engagement of what they see. I think it was right around 20%, 17%, so we're not too far off. In the beginning, it was a little bit lower, but it sounds like they've really tried to do some things to ramp up and engage with these members a little bit more. So we can see engagement is trending in the right direction. And then it breaks up between subscriber, spouse, and dependent. And then there were some key outcomes that they shared regarding their program. You can see clinical outcomes. 75% are regularly checking their blood sugar, and it's in the normal range in the last 90 days. They've seen a reduction in the estimated HbA1c numbers, so down about 0.58%. So you have that there. And then what exactly are these members engaging in? 71% are doing device monitoring, 85% are doing the self-guided activities through Livongo, 42% in digital coaching, and then 7% in expert coaching. So the members, go ahead, Tom.
The thing that jumped out to me was the top numbers don't seem correct for MODA members that we have. Looks like it's off by 25,000. I thought it was 100,000 MODA members.
That's correct, Dr. Siltabo. We have about 100,000 total members.
Okay, so fix that. And so when we look at the around patient program engagement, I just Matt, make sure I've got it right. So assume these were the percentages by in March 2021. So you would multiply to get the actual percentage of total diabetics who are using this. You would multiply, like the last one, expert coaching, 7%. You'd multiply the 7% by the 17% to look at, because those program engagements are only out of the
That is correct.
881.
That is correct.
Got it.
Yep.
Okay, good. Thank you.
Yep, the members that are actually enrolled in the program, what are they actually engaging in?
Yeah. Okay.
You're 100% correct. And we'll go back. I pulled this data from the MODA report, so we'll circle back with them and confirm on the total numbers.
Okay.
But thank you for that call out. So this is the Livongo program, obviously, that's available for the MODA members, and sort of where the participants are at. Are they moving in the right direction? Is it being impactful? So this was the data that they were able to provide. Now Rose, was there any questions on the MODA Health Livongo before we go over to the Kaiser Prevention and Lifestyle Risk Report?
This is Dr. Popowich at MODA. The only thing I would tell you is I do have the most current report through the end of June. And we're now up to 928 enrolled, so it's 19% of recruitable. So it's still going in the right direction.
Great.
Awesome. Thank you for that, Dr. Popovich.
Sure thing.
All right. All right, so it doesn't sound like we have anything additional. So Rose, if you want to go ahead and go to the next slide. So this is our Kaiser Prevention and Lifestyle Risk Report. This is pulled through Q2 2021. So this is very up-to-date data. And what the Prevention and Lifestyle Risk Report is, and I'm sure you're all familiar with it, is that what it does is it collects the biometric screening data from your Kaiser members as they actually go in to see their physician. So, one of the advantages of Kaiser is an integrated health plan. The doctors, ask the data or ask the patients for the data, and then they can actually report out aggregate numbers for us. And so what I did is I took a look at this report and I pulled out all the data that I thought that would be beneficial for our discussion today and sort of give us a snapshot of where your OEB Kaiser members currently are at. So you can see the subscribers, the members, the average age, and then we break it out between adult, weight, overweight or obese, exercise, and then pre-diabetes, and then the trend over the years. So you can see with adult weight for the OEB in Q2 2019 to OEB Q2 2020, sort of the trend there. We're up about 1%. We're a little bit higher than the regional average. We're about 4% higher than the comparative national average. This was one that really jumped out to me here. Adult exercise, so not meeting the minimum requirements, and the minimum requirements are going to be the 4 to 7 days per week for 30 to 60 minutes. Those are the requirements that they have stipulated there. You can see in Q2 2021, 66.3% of your OEB members indicated that they were not meeting that minimum, and then the comparative national average is about 47%. So we're significantly higher for individuals not meeting the minimums for exercise. And then you can see your pre-diabetes, and your pre-diabetes numbers were actually better than the national comparative average, but we're going to talk about those here in a second. Then I sort of broke that down so you can see the sort of trend between, because you might look at that and say, well, what's overweight versus what's obese? So you can take a look back in 2019, you had 31% overweight, and then 30% as we got into 2020, so it's heading in the right direction. But what it looks like is happening is that some of your overweight people are trending towards the obese scale. So you can see the overweight going down in 2021, but it's going up in obese. And then one of the things to just keep in mind as we take a look at the graph to the right, you can see pre-diabetes was at 26% in 2019. In 2021, it had dipped to 22%. But you can also see that OEB saw a dip in your diabetes screening rates. So what can happen sometimes is that if individuals don't make any changes, or they have an idea that they're probably still in the same boat where they're at with their weight and their diabetes, that they may not go back. COVID could have also played a part in that. Of people, I think we all know that health engagement across the board is in terms of going into your physician to see and get appointments is down just due to COVID. Had some impact on that, and then sedentary lifestyles. But the big thing that I want to sort of point out here is this gray graph, this gray box on the top left. And you know how we talked about in the beginning that there's 88 million Americans who are pre-diabetic, but 85% of them aren't aware. And this is the potential cost associated with that. So just if we take a look at your individuals who are overweight or obese, medical costs associated with weight for those members is about $28,580,028. And also, only 46.3% of your group was measured in the past 12 months. So this is only 46% of your group that was measured, and the cost that Kaiser associated with those members who are overweight. And then if we take a look at inactivity, there was another 10.8 million in inactivity costs. And then again, you can see only 46.5% of group was measured in the past 12 months. So that, more members that got measured, that could have an impact on that number. And then your diabetes costs, so you have your weight, your inactivity, then your diabetes, about 1.8 million of costs associated with diabetes. And again, only 50% of your group was measured. So the total medical costs associated with weight, inactivity, and diabetes on the Kaiser report that they provided was a little bit over $41 million. So any questions on this Kaiser Prevention and Lifestyle Risk Report here? I really like this report because I think that there's a lot of opportunity on this page. I always look at this page as there's a lot of opportunity on this page if we can engage with these individuals and get them headed in the right direction. All right. right, so going on to the next slide, please. All right, so basic practice plan, sponsor approaches in diabetes management. First stage that what we want to do is conduct a current state evaluation, which we're sort of doing a lot of that now, right? We're looking at your medical and RX claims, data warehouse. Jenny and her team pulled some data out of the data warehouse to share with you. Inventory asset of current benefit programs engagement, which we're gonna jump into here in a second. Define potential performance gaps and opportunities for improvement. High risk cohorts based on social determinants of health, disease state, risk, or geography. Just in a sense of time, we're not going to dive too much deep into this, and then develop a strategic plan to improve engagement, risk profiles, and outcomes, which we're going to talk about here later. Rose, in the sense of time, if you want to just go ahead to the next slide, please. All right, so best practices for supporting members across the diabetes spectrum. Now what we're going to do is we're going to get into the diabetes spectrum, where we're at, and what currently solutions that OWEB has in place to make an impact in these areas. We're also going to share with you a new sort of term in the market. You may have heard this out there today, called diabetes reversal. There are vendors in the market right now that specialize in diabetes reversal, which we're going to share one of those with you today so you can take a look at. But you can see for pre-diabetes, metabolic syndrome, and weight management, the current OWEB solutions, I mean, the best practices, we're not going to spend a lot of time in that. We're going to jump right to the solutions just in the sake of time. You can see you have the Motor and Kaiser health coaching and weight management programs. You have the Canary Health virtual lifestyle management and DPP program. You know, through Canary Health, you do have the Better Choices, Better Health program. But one thing to keep in mind in that is that that's not a specific diabetes or weight management program. That is a program of peer groups that you get with that help you support you on your stages of change and where you're at with a condition. So I had a couple extensive conversations with Canary Health, and they did not want to be categorized as a diabetes solution program. That's not what they are. They're just a peer review group where you get support in the area that you want. So you have Canary Health, you have the Kaiser Diabetes Prevention Program, so Kaiser has solutions. You have Livongo for Moda Health. Then you have WW and their weight management program. And then one thing to keep in mind is that we're getting ready to launch the Stay Well WebMD 1 platform, which is also going to have diabetes, nutrition, exercise, stress, challenges, daily habits. They're going to have a bunch of information there that's going to be available there to your members. So we have several solutions in there for the pre-diabetes, metabolic syndrome, and weight management. Then once we get down to diabetes management type 1 and type 2, you have your Kaiser Care Management Program, which is available. You have Livongo with Moda. And then Moda Health 360, which is another program that Moda has available for their members, and then WW Proposed. So we haven't made that decision, but that is one that we could technically take a look at. And then Diabetes Reversal, which we're going to talk about here in a second. We don't have a solution available for that, but there are some there's a very new age technology, a new vendor that you may be aware of, we're going to talk about here in a second, that does provide this, and they are seeing some tremendous success in the market. So, and then one key point too that we do want to point out to the team is that with any health management program, plan sponsors should look for a way to integrate with existing condition and disease management programs. So when we make these recommendations, we move forward, we want everything directing back at the carriers, those primary care physicians, to getting them in care with their first stage there. So any questions before we move on to the next slide?
I might just interject one thing, Matt, and that is, you know, I think one of the central questions that we're grappling with, I think, in this presentation is, are more solutions better, right? Is it better to offer a lot of things and meet members where they are, or is it better to have fewer targeted solutions? And honestly, there's, I think there's merit in both sides. However, that last piece that Matt just mentioned, which is how do those programs direct the member back to their treating physician, has always been pretty central for OWEB in terms of importance. And so I think as you're thinking about, are more solutions better, I think it's a really good idea to take a look at how that solution directs the member back to their treating physician and helps coordinate care. And I think, Matt, you're going to get into that on the next slide.
Yep. Thank you, Jenny. That's a great call out. So Rose, if you want to go ahead to the next slide, please. Oh, Perfect. So we put together this graph for you just so you could take a look at your diabetes care vendors. It's a little bit more of a visual graphic for you so you can see where your current vendors at and where they're providing assistance. So you can see for diabetes or pre-diabetes diabetes prevention program, you do have the Canary Health DPP program that's available. Kaiser has some DPP programs, some diabetes specific information to help prevent diabetes, weight management. You have Livongo that's available. You have WW that does provide some, weight management, recipes, some support in that area to help individuals control their blood sugar and manage their weight. And then we look at diabetes management. You have the carriers. You have Moda Health has programs available. Kaiser has programs available. The Livongo program is available for diabetes management for the Moda members. WW does provide some solutions to help individuals manage their diabetes, just in terms of weight management, A1C management, recipes, those things like that. And then the new sort of player in the market today, and I don't know if the team is available, the SEOW team is available or aware of this new group, but there is a new vendor in the market by the name of Virta that specializes in diabetes reversal. They've rolled out this diabetes reversal program. It's pretty intensive. It's pretty intensive with its coaching, with its nutrition counseling, with just sort of the solutions and the resources and the measuring, the remote monitoring, blood glucose monitors that they have available. But they've been very effective in helping reduce medication, so claims for medication, getting people off medications, reduction in A1C and weight. And one of the things that Virta is willing to do is that they're willing to put 100% of their fees at risk in regards to these 4 performance guarantees. So they put a lot of their skin in the game in regards to being able to be impactful with the population. And so just something for us to keep in mind as we go through and we take a look at these solutions. So Rose, did you want to go ahead to the next slide, please? All right, so here's sort of the breakout, and we're not going to go through this verbatim because there's a lot of information on this slide. But if we sort of measure the vendors and the point solutions sort of up, in the carriers of what's available, you can see the Canary Health column there. You can see Kaiser Permanente, you can see Moda, you can see WW. You can see also, to Jenny's point, one of the things, integration with the member's primary care physician. Does this group do it, or what's the modality and how they do that? The diabetes care, the services that they provide, the services provided inside of that, how their members are connected and outreach, engagement, outcomes, and then cost. And I think, sort of my big takeaway when I was building this slide and sort of taking a look at the solutions that are available to you is that currently that there are a lot of solutions that are available to the OEB members in regards to weight management, type 1, type 2 diabetes. There's a lot of stuff that's available for them. Do the members know where to go to get these solutions? What's the proper outflow? Where do I start? Who do I engage with first? Where do I outreach if I'm a Moda member or if I'm a Kaiser member? What's available to me? So I think that might be, and we're going to talk about this in the considerations and recommendations, somewhere where we maybe want to begin to build that out, and then take a look at the gaps in care. In regarding to your Kaiser population, Moda Health has their Livongo program and their chronic condition management program. Is there something that maybe we could provide to the Kaiser members that's similar to a Livongo? I don't know if that's something that we want to take a look at. But in regards to WW, a couple things to keep in mind, and we're going to talk about this here as we get to the next slide, is that for their diabetes program, it's not one-on-one coaching. It is just personalized coaching from credentialed professionals, certified diabetes education specialists. They have type 2 created and tailored materials, and then weekly workshops. So it's not going to be something that's really intensive that these individuals are going to have access to. It's going to be more general information. They're going to be giving, hey, the CD education person done this workshop, and here's a video that you can watch and things like that. Also, one of the things when I asked WW just regarding the coaching, and this is how it came up, the reporting that they would be able to provide to us just in regards to how the member is moving along and their stages of change, and are they making are they reaching their goals. That's not currently in place for that program too as well. So these are all things for us to keep in mind as we take a look at the different solutions and what's available. So I know that there's a lot of information on this page here. Was there any questions, comments, or concerns? All right, I'll take that silence as a no. So considerations, we sort of talked about this. So there's 5,500 OEB members that had diabetes in 2019-2020 plan year, representing 25 million in spend. It's consistently one of your top 5 conditions for OEB in terms of spend. So what that tells you is that spend is going to continue. It's not going anywhere unless we really get some interventions that can make an impact in this area. We currently have weight management or diabetes care, DPP type 1, type 2 solutions provided by the following carriers vendors. You have Canary Health, you have Kaiser, you have Moda Health, you have Livongo, you have WW, and now we're going to have Stay Well WebMD. So I think that's 6 or 7 solutions that are currently available to your OEB members in regards to making an impact of this area. WW has proposed implementing their diabetes coaching program for 2022. This solution is similar to services solutions already available to OEB members. So they already have some coaching elements and things that they can get through the carriers. So they have that available to them today. Now, here's the thing. Due to brand recognition, WW Reimagined has significant engagement. So they do have a lot of active members just due to WW and people that know their brand and have used it in the past. But as we discussed, that they're active in health coaching reporting. We need further capabilities. I'd like to see that built out a little bit more. And then they have confirmed no pricing increase for their diabetes program in 2022, but cannot confirm pricing for 2023. So that could be problematic for us. So Rose, if you want to go to the next slide, please. Thank you so much. So this would be my recommendations and next steps. I would focus on increased engagement with your current vendor programs before implementing any new solutions. You guys are getting ready to currently launch your WebMD 1 platform on 10/1/21. We're really involved in that. Jackie, Margaret, Glenn, the team has really been great in helping support that. So a lot of our eyes and our focus are focused on making sure that that program launches successfully and we drive engagement and really, hit the ground running with the wellness champions and the different entities. But also, I had conversations with Canary Health, with Moda, with Kaiser, and just regarding what's currently available there. We all think that there's an opportunity for us to really drive significant engagement in the programs that are available in Livongo, in the Canary Health program, in some of the Kaiser programs that are available out there. And then also you have the WW program that we can still leverage and we can still promote. So look at a specialized communication directed at members with diabetes, prediabetes, create a weight management and diabetes care flow chart, maybe something for Kaiser members, for Moda members. So, and Jackie and our communications team is already working on a wellness brochure to really bring those solutions to the forefront to make sure that it's very easily navigatable for members to go in and get connected with the solutions that make a positive impact in their areas of health. And then one of the things that we could take a look at doing, and I just did this for one of my other clients, is taking a look at the different solutions that you have available. We have what's called a value impact dashboard, where you can plug these different vendors into it's a pretty rigorous data analysis process, and then we can provide to you, impactful data on how these different vendors are performing, how the solutions are making an impact, really for $1 so you can get a look at the true ROI value of these different vendors. But the recommendations, focus on engagement with the current programs, and then let's take a look at really what are these current solutions, promoting the current solutions, and then at that point, if we feel like these solutions still aren't the ones that meet our needs, then we take a look at perhaps a new solution that could help us be more impactful.
Matt, did you say anything that the Weight Watchers program for diabetes, do they do any finger sticks for glucose levels? Are they getting any data anywhere for that?
No, not that I saw. I go back and double confirm, but it's just a digital program.
So if we go all the way back to one of your first slides where you're talking about stage 1, 2, and 3, what concerns me about that program is I don't see taking into account blood pressure any A1C3, any kidney function, any lab works. I'm concerned that somebody could get into that program and have a false sense of security that they are holistically treating their disease.
Yeah.
Tom, do you have a reaction to that?
Yeah, I'm the fact that the WW for diabetes is while they are, have talked about this, focused expert diabetic educators working with diabetics, it's disconnected from the rest of the rest of the delivery system, and because of that, it's disconnected from all as the issues that you just mentioned. Diabetes by blood sugar is not the only issue. It's blood pressure control. It's being on statins. It's monitoring kidney function. All of those issues. So while it is a part, it's not enough. And I think what you're raising is that if people say, hey, I'm connected in this great program and I'm doing X, what the risk is that they're missing Y and Z. So those are the concerns that you're raising are ones that I have also. So in terms of the recommendation that is discussed, I'm in favor of that also. And one of the things that when you talk about the last bullet, so did I answer your question, Jeff?
Yes, you did, sir.
Okay, so the last bullet is measure results of targeted efforts. Really, the bottom line is how well are we managing, are our vendors managing diabetes? And we've been collecting this data for a long time, and we know that the COVID has decreased the way that we're managed chronic diseases and also prevention and early detection. We know that, and yet we need to be looking at how well our carriers are performing. And so we have things like diabetics percent in poor control in regards to hemoglobin A1C. Those that are we should be looking at diabetics who have hypertension and what their control is. We should be looking at diabetics eye exams and all of that. That's data that we've collected, and we can bring that back to the group and have conversations with our carriers about specifically, for like Kaiser Permanente, what is their, what's happening with their care management program vis-a-vis the clinical outcomes that they're seeing. Same with MODA and what's happening with their clinical outcomes and what percentage and what's happening with Livongo. I mean, I think the problem with Livongo and any of these programs is that they are working with people who have the interest in making a change. And so, we're up to 19%. That's great. There's 81% who aren't part of it. So what the heck's happening with them? And we won't get healthcare costs under control by focusing on the 19%. We need to be able to figure out how to, work with the 81% also. So this is I think I agree with the recommendations that are outlined. I think we asked our consultants to try to figure out, to give SEOW a reasoned a framework where we could look at what's happening and to be able to address the issue of what Weight Watchers proposal is. The fact that it is disconnected not just from the primary care providers, but then disconnected from looking at the totality of the issues that diabetics face, I think is a huge issue. And I agree with the focusing on increased engagement, and that again means looking at the totality of the diabetic population, not just those who are for that particular moment actively engaged in change. Those are my thoughts.
Okay, so adding on to that, I really think that for me, the integration with the primary care provider is key. I don't have the data to back me up on that, but it just, if not having a connection is of concern to me. And then I don't know how to quantify this, but in the future, I'd like to know what impact does integrating with the PCP have on engagement? Because to me, the PCP, the primary care provider, is the person that probably sees this person on a more regular basis, especially the ones that aren't taking advantage of these third-party vendors.
Right.
Yeah, I think definitely with that integration with the PCP. And I know we had the doctor here from MODA, and I don't know if you want to chime in here and just share with the group a little bit about, because it sounded to me when we went through this process that one of the first ways that a person can engage with the Livongo program is that they come in to see their physician, and their physician gives them, high blood sugar or high information regarding their A1C, and then they're offered that information or directed in that program. Can you walk us through that a little bit?
We focused on the Livongo specifically, or a variety of these offerings?
I would say both. I would say Livongo and then the Moda 360, because I think both of them provide coaching and support for diabetes.
Yeah, that is a huge part of Moda 360. Obviously, there's a variety of point solutions here. We equally share and recognize the need for PCP integration, thus the platform where we collect and pull together all the data. We collect the data from all the different vendors. We ensure that we're still targeting all the right members, and that data is shared and made fully available to the PCP. These vendors can and should do more to work more directly with the PCPs. Obviously, with diabetes, is a serious multi-system disease. Earlier stages, these solutions are probably highly effective. They're probably useful later stages, but at later stages, you absolutely do need the PCP and then, unfortunately, specialist care, multi-system, multi-organ disease, and these solutions won't be sufficient. Thus, the PCP 360 in coordination with Moda 360, where we constantly review those members that are in greatest need, and then ensure that they are actually attending at the physician office, getting that interdisciplinary team care.
Thanks, Dr. Singh. And I'll add just a few more comments about how Moda 360 is working with Livongo and with the PCPs on trying to increase engagement in Livongo. And the first thing I just want to point out is right now we're at 19% engagement. And if you look at the history with Livongo, so we just implemented that this year, so we haven't had it for a full year yet. And the engagement in the program just increases every month. So we do fully expect the engagement to continue to increase, and that we will be over that 20%, especially with some of the interventions that we're doing to try and get members engaged. So a few of the things that we do for Moda 360 is first, every time a member is working with someone at Moda, so whether that be a health navigator or one of our health advocates through Moda 360, those navigators and advocates are working in our system, and there's an alert that shows them if we have invited a member to participate into Livongo, and if they have engaged with the program. And it also shows them, when we've communicated with the member about the program as well. So every time we're working with a member who has not yet engaged with Livongo, that is a conversation that we have. And then our team will follow up with members either through email or through phone calls to try and get them engaged in the program. And then we also have care reminders that are in our member dashboard and will be implemented by the end of this month. So when members log into their member dashboard, it'll also notify them if they're missing an A1C test, and then it will also be notifying them if we have engaged them in Livongo, if we have invited them into Livongo. And so it'll also be pushing that through the member dashboard. With the PCPs, we are implementing a report that goes to our PCPs that tells them which members we have invited into Livongo and which ones have engaged, so that the PCP can also have that conversation with the member and get them enrolled into the program as well.
So as we look forward to more data, and it would be very helpful to be able to track the clinical outcome data on whether or not the person is in Livongo or not. So the issue of percent of diabetics in poor control, the percent of diabetics who are on statins, there are the eye exam measure, and I think we're still following. There's a couple others. So whatever that diabetic bundle is that we have, it would be very helpful when we get this next year's, shoot, it's not going to work. I was thinking that we'd be able to look at it this year, but we're only going to have 2020 data at the end in the fall of 2021. So Livongo hasn't been around, so we're going to have to wait. But whatever you can do in terms of looking at clinical data would be, in terms of being able to see the efficacy of Livongo, will be very helpful.
Yes.
Yeah, so whatever you can do. I mean, it's relying on HEDIS is the delays are so great. It doesn't tell us much, and I don't know whether or not what type of connection you have with your delivery system that that allows for more real-time measurement of clinical data.
Yes, great point, Dr. Soltabo. And I do know that we will be doing a year-end report on Livongo with outcomes, and we can touch base with you on incorporating some of your thoughts into that.
Okay, good. And so when I would like to also hear from Kaiser Permanente about, but I also don't want to cut Dr. Singh and yourself, Erica, off. Did you finish your comments?
Dr. Singh, do you have anything else to add?
Well, we do that type of periodic analysis with all our vendors, but as you indicated, this is still early stages, but still incredibly useful. So we will do that. We'll look at the available clinical data. We do receive that supplemental clinical data from a sizable part of our network, including
that's what I thought.
So,
yeah,
so we can do some of that analysis. We don't get it for all.
I understand.
Yeah, network. Thank you.
We'll it's the difference between being a health plan with multiple delivery systems versus a single delivery system. So I get that.
Yeah, I think there'll be enough data there to run that analysis to get an idea.
Love to see it when it comes.
Thank you.
Tom.
Thank you. Yeah.
Jeff here.
Yes.
Without going through a full report, I'd love to see an update on pages 8 and 9 at the end of the plan year when that's available.
Okay.
Just because obviously we have enough people that are diabetic or pre-diabetic that this is one disease we need to keep close watch on.
Yeah. Yeah. Its implications are across so many different clinical arenas. Glenn, did you get that request from Jeff?
I got it too as well. Update on
okay, super. Thank you, Matt.
Yep, for sure.
Super.
Thank you.
Dr. Bachman.
Yeah, we definitely agree that the importance of looking at metabolic health across the population, including those with established diabetes and diabetes with complication, is really critical for OEB and SEOW to be doing. I mean, this is not new information. Things are worsening. I think the data related to COVID and weight status in both adults and kids is concerning, that we are going to be seeing increased risk of diabetes and increased risk of metabolic disorder in our population. I think that's pretty clear. I would say simplicity is important in an integrated delivery system with the primary medical home in the center, with the relationship between a member or patient and their physician with ancillary support around it, which includes team-based care involving diabetes education, pharmacy support, integrated lab monitoring, and blood sugar monitoring. All that really is the way to go. I would caution, we're looking at vendor outcomes, given that that's only a small portion of the population that avails themselves of an individual vendor. So really keeping an eye focused on overall diabetes outcomes in the population, such as using the HEDIS metrics that Dr. Siltabo was mentioning is really critical, along with behavioral biometrics as well. So I would just say that you can add vendors and add complexity, but that may not always get you where you want to go, and will definitely increase complexity and probably increase cost as well. So.
All right. So I am taking, this is one that I would like to have kind of an explicit, it's in a way it's a vote. I've heard from the two other SEOW members, but I want to confirm that our recommendation to the board is that we follow what Matt has outlined for us, that we focus on the increased engagement with current vendor programs before implementing new solutions, and that we direct our carriers to focus on ongoing communication, and that I think we do need to spend some more time being explicit in terms of the diabetic set of clinical measures that we look at. And I agree with Dr. Bachman. What matters is what's happening to the total population. If there's good work happening by these special activities, they will move the total some. So we will, but what matters is what's happening to the total population. Is that a fair? Is that capturing what the recommendation?
Yes.
Yes.
Okay. All right. So that's what we'll bring to the board, and we'll communicate. We'll have our staff communicate after the board hears this report, and if they agree, great. If they don't agree, then we go somewhere else. But we'll communicate with WW on this. Anything else, Matt? Is there anything else that you would like for us to think about, or have we finished off on this one?
Yeah, no, I guess there is, since you asked, there is something that, and I've talked with Glenn about this, and I know that there's some barriers, but I've worked with also other school district conglomerate groups like yourself who found a way to make this happen. And, one of the things that came up, and you had mentioned this, you said, okay, that's great that we have 19% of people that participate in this, but what about the other 81%? And whether we like it or not, there's a certain large bucket of these individuals who could really benefit from this, that would maybe really think about getting engaged if there was some type of incentive involved. And so I understand that there's some complexities and things that we'd have to navigate around, but instead of offering another vendor, if you were to take a portion of that money and just give, an incentive out there for people, I think that would be very impactful, especially among school district populations. I've seen it happen in getting these people to at least register and get started with it. So just something for us to keep in mind here for further meetings.
Okay, so we'll put that on our question list. I think that one of the complexities is that OEB provides these options to entities, and it's the entities that have the financial relationship with the member. OEB doesn't have the relationship directly with the member, so I know that there's been issues around this throughout. So we'll take that under advisement. We've had incentives for other things before, and they haven't been as targeted as what you're suggesting. Matt, I want to thank you for your analysis. You overwhelmed us with information, but the good news is we had time to read it all ahead of time, so that
Awesome.
we could probably pass a test on it if it was
Perfect.
good. Okay.
I always like to over deliver, so I'm glad that it met the mark.
Yeah. Okay. Anything else for the good of the order, or I think we're done. Glenn, anything else? I don't see Glenn on the list at this point.
He's on mute. Glenn, you're on mute.
Sorry. I just would ask Rose whether we have any public comment.
Right. I keep forgetting that, even though it's on my agenda.
No, there's no public comment.
Okay. All right. We are adjourned, and we will gather again at 1 o'clock for the full board meeting. Thank you all. Thanks again, Matt.
Thank you.
Bye-bye.